exciting event. I'm Paul Gessing. I'm the head of the Rio Grande Foundation, your event sponsor this evening. And looks like we had a little more space. I wish I'd known a few people were going to show up. We had to turn away 25 or so people at the in the RSVP department. But thank you all for coming, and I think you'll be in for a very interesting evening. I'm going to introduce a few Rio Grande Foundation staff. Can you stand up, Krista? Food and et al. And my wife. Corey Davis, our intern extraordinaire. And one board member, Ben Alimo, is here. Oh, there's Luke hovering in the corner. He is our newest intern for the fall and spring semesters. So this is our first ever Rio Grande Foundation sponsored debate. I'll be interested in all your thoughts. I have comment cards that are placed on each chair, and we do that for two reasons. One, to get your contact information so we can start spamming you. Just kidding. But actually, really, we're hoping that you can give us your information, find out about future events, and give us your thoughts on this format, the debate format, and the event in general. We, of course, are a nonprofit organization, 501c3. That means tax deductible, so I encourage you to donate to us and support us so that future events like this can occur, because we do rely on the support of our donors to continue our work. I'm going to go over a few formatting questions and ideas here with you. If you have not already put your name in the basket out front, you should have gotten a slip of paper at the door. We will put them in the basket, call your name, and then you can ask your questions. So you don't have to have your predetermined question. As the debate flows and moves forward, that question in your mind can change, and so it pays to take notes and pay attention to the whole debate so that you can have a ready and relevant question when your name is picked out at random, as it may be. Each of these gentlemen will have a 5-minute opening vision statement for their own views on what healthcare should be like in this country. And I want to welcome our friends at KUNM. Thank you for coming. And this will be posted on their website. It's not going to be live broadcast. My understanding is that there will be a news story of some length with snippets of the recorded material from this discussion, and then the whole thing will be posted on their website. And we are videotaping it as well, so the whole video will be available on our website, which these two attractive gentlemen, you surely want to be able to see the video of that, not just the audio, but in a pinch. Let's see. Oh, and the Albuquerque Journal's here. Sean, thank you. So look for an article in the back from him. Tomorrow, I'm sure, first thing in the morning, right? And I want to, before we really introduce these two guys, I want to do a poll. I want to do a before and after poll, if you will, to find out where you all stand. And if I can get someone to make a notation here, or someone help me count. I believe four different categories of people, different stances on healthcare. How many of you consider yourself a supporter of single-payer healthcare? I knew it's tend to be our donors and our supporters. So we have about 1, 2, 3, 4, 5, 6.
Program.
Single payer. Oh,
you give the options before you.
Yeah. Okay, sorry. Single payer, the Obama plan, loosely defined, which includes the public option in its current format. Status quo, or moving towards free market solutions. So, sorry. Single payer, I saw about 10 to 12, maybe 15 hands up. Obama's plan. Okay, you guys are raising your hands twice. So,
Now that we know the options.
Okay. Okay, we got about 8 to 10.
Early enough.
Status quo. This is a status quo. Only one status quo support. And moving towards market-based solutions. Okay, we have, great, excellent. So you're gonna have to work very hard to continue to add to that, Michael. But, all right, our two esteemed panelists are Carter Bundy and Michael Cannon. Carter is the Political and Legislative Director of the American Federation of State, County, and Municipal Employees. I got in trouble for not writing that out in the press releases last week. I said, it's so darn long.
I didn't get in trouble.
No, not from you, not from you. In New Mexico, he runs AFSCMEs lobbying efforts essentially here in New Mexico. Prior to working for AFSCME, he was State Director for the Gore-Lieberman campaign. Before entering political and policy life, Carter was a commercial litigator in New York for 5 years. Also worked for a business consulting firm right out of college. He received his BA in Foreign Affairs and History from the University of Virginia and his JD from the University of California, Berkeley, including work in law and economics. Earlier this year, Carter completed the state and local government course at the Kennedy School of Government at Harvard. Carter was also a member of Governor Richardson's Health Care Task Force, which examined multiple competing health structures. He lives on the west side of Albuquerque with his husky lab mix named Lacey. So give Carter a... Hey, we might disagree on healthcare, but we have a husky too, and you have to be full of love to have a Siberian husky, so we'll give you a point in your column right there on that, Carter. So Michael Cannon is the Cato Institute's Director of Health Policy Studies. Previously, he served as domestic policy analyst for the U.S. Senate Republican Policy Committee under Chairman Larry Craig, where he advised the Senate leadership on health, education, labor, welfare, and the Second Amendment. Cannon has appeared on ABC, CBS, CNN, CNBC, C-SPAN, Fox News Channel, and NPR, articles in newspapers all over the country. He holds a bachelor's degree in American government from University of Virginia and master's degrees in economics and law in economics from George Mason University. And he is here because taking time out of his vacation. His wife's family's from Santa Fe, and so it's I appreciate very much your offering to do this. And by the way, these two will be doing it all over again on Wednesday morning on Bob Clark's show from 9 to 10 on 770 KKOB. So if you can't get enough of the healthcare debate and what these two have going, tune in to that, call in, and let's get started. I'm going to do the, since this is debate style, we're going to do a coin flip. You are the home team, so we will flip the coin to see who gets to answer the first question. So, tails it is. Okay. Does anyone have the basket, please?
Were we going to do questions or opening statements?
Oh yeah, opening statement. Yeah. Go ahead and Michael do the opening statement.
Why don't you go ahead? Okay. First of all, thank you all for being here. I think this is obviously it's an incredibly important issue to discuss. I will tell you that I've been working for AFSCME for, this is my 9th year working for AFSCME, and this is the single most important piece of legislation I think that we've worked on. Whatever you've heard about Employee Free Choice Act or trade bills, this is it because it really affects everybody. So thank you for being out here and being part of this. You know, I think a lot of people justifiably are scared. We're talking about changing 1/6 of the entire United States economy. And we're talking about doing some things that are going to upset some very well-entrenched moneyed interests. But something has to be done. I think a very telling statistic is one we just saw from Paul. There's only one person in the room who thinks that the status quo is where we need to stay. I think there's widespread agreement that for the amount of money we put into the American medical system, we're not getting our money's worth out of it. We're not getting it in terms of healthcare outcomes. We're certainly not getting it in terms of access. And we're not getting it in terms of peace of mind and certainty. You know, one of the real flaws in the current system is that you really aren't sure, even if you have insurance, that your family's really going to be okay. 70% of all bankruptcies in America happen because of healthcare. 2/3 of those people have or thought they had health insurance. This is a really serious problem. You know, you guys probably more than most have heard these little jokes about what do you call a Democrat who's been mugged or Republican. What do you call a Republican who has a catastrophic health event? A Democrat. Because a lot of the time you'll find out, and it's not really partisan, especially with Cato and Rio Grande, but you know, a lot of the time people think the market just cures everything and that they have their health insurance and things are great. And they find out one way or the other. Either they get denied on a claim for a technical reason, they find out that they just get denied for no reason, and then they have to fight like heck just to get a small claim covered, and I'll tell that personal story later if it comes up. There's a real misalignment in the American system between the incentives of the people who really hold the key to access to healthcare, the insurance companies, and the people of this country who just want healthcare when they get sick. So I think regardless of your ideological bent or your party affiliation or whether you like President Obama or Harry Reid or anyone else, I think we have to acknowledge there are real problems in this country with the way that healthcare, especially the financing mechanism and the middleman, is handled. An important thing about this bill, and yes, I have 3,200 here, and yes, I've read it. How many people have read the bill? Okay, so I could just say anything about it. He hasn't read it, so I'm just going to say this is the bill. No, I'll tell you, actually, you really should. The first 200 pages, first 215 pages, and it's double spaced, it's big margins. I mean, it really you can get through it. The first 215 pages, I would recommend you read. That's really the structural changes that we're talking about. And I think what will comfort a lot of people once they know more about this, and there are a lot of different bills. There are 4 different committee bills that have passed out, and Senate Finance will have one in October probably. The first 215 pages really deals with the structural issues, and even though there will be changes, and actually this bill has changed, it'll give you a feel for what the general concepts are: the employer mandate, the individual mandate, the guaranteed issue, which means that you can't be denied coverage because of a pre-existing condition, the no rescission clause, which means that they can't kick you off if you develop a condition. There's a lot of stuff in here, and it's amazing. Actually, I almost feel like there should be a Republican here too, because libertarians may disagree with Democrats and Republicans on some of this. There's actually widespread agreement on a lot of core issues like employer mandate, individual mandate, guaranteed issue with some kind of community rating. The details are still, there's disagreement on, but there's really widespread agreement between a lot of conservatives and liberals, and again, not necessarily libertarians, it's really different. But there's a lot of agreement on a lot of key things in this bill. And I think for people who have insurance, and I think most people in this room probably do, there are a lot of really positive things in here that are going to make your life and your family's life a lot better in the event, you know, knock on wood, it doesn't happen, but we're all human, in the event something happens to you or your family. So I hope that we get into some of the details of the bill, some of the reasons for it, but I think this is a real opportunity for us as a country, and it's, there's a lot more common ground, I think, than a lot of you might imagine, and it's important that we get a lot of this done because it does change how all of us live going forward. And thank you all for being here.
Is that HR 3200?
Yes, it is.
Thank you.
All 1,017 pages.
Thank you, Paul. Thank you for putting on this event, and thanks to the Rio Grande Foundation, and thanks to Carter for agreeing to share the stage with me here. I'm really most interested in what your questions are, so I'm going to run through, I think, what are some good guidelines for the current healthcare debate and really any debate on any public policy issue. And there are 5 of them. Well, last one's not a guideline, but the first one is, with all the craziness that's been going on at town hall meetings around the country, specifically over this topic, I think it's a good thing if we all come to this debate assuming that even those, whatever your perspective is, assuming that everyone who disagrees with you has good intentions, that they want the same things that you want. They want healthcare to be more affordable. They want the quality to be improving constantly. They want to make healthcare more available to those at the margins in society. Those, we're not really worried about the rich here. We're not really even, it's getting more, less and less affordable for the middle class. But what we want to be, I think we all want, is to make healthcare of ever increasing quality available to an ever increasing number second guideline is keep in mind that perfection is not an option. Healthcare is a human endeavor. You're never going to achieve a perfect healthcare system. Tom Daschle, who's a former Democratic Senate he was both minority and majority leader, wrote a book called Critical, where he made, I think, a really important observation. He said that even if we achieve universal health insurance coverage, some number of people will still fall through the cracks. I think that was an important admission, and I think I can make that about my ideal of a free market healthcare sector. That is not going to fill in all the cracks either. There will still be people who fall through the cracks. I do think that one advantage of freer markets is they fill in those cracks over time, and my view is that government tends to make those cracks wider. Number three, if this were easy, we would have done it already. So there really aren't very many simple solutions. Well, maybe some are simple, but they're not easy. Number four, one of the reasons, and this is not easy to do, reform healthcare, make it more affordable, reduce healthcare spending, is that reducing healthcare, every dollar of healthcare spending is a dollar of income to somebody. And that somebody usually has a lobbyist. And that's actually, from my perspective, one of the disadvantages of letting these decisions be made through the political process, through government, is that when there's waste and when there's inefficiency, well, waste and inefficiency hires a lobbyist. So it's very hard for us to reduce spending. And lastly, I've given you a little bit of a taste of my perspective on healthcare. I really look forward to engaging on the bill and the evidence that we already have, say from Massachusetts, about what the president's approach for healthcare would look like in terms of how it would affect our healthcare. But I just want to offer you this. If I say anything that you think is incredible tonight, if I offend you with any of my views, I think you'll be very comforted to know how little influence I have in Washington, D.C. With that, I look forward to your questions.
We're going to call 5 names out. I'm going to draw them right here.
And while he's doing that, I just want to say, I don't know if you all noticed, but we both went to the University of Virginia, and we both had Ken Elzinga as an economics professor who's sort of famous, and everyone at UVA takes a few of his classes. So Professor Elzinga, I think, would be
bemused.
Yeah.
During lulls in the debate tonight, we'll be filling in the silence with our own favorite Ken Elzinga.
First question, Tiffany Fisher or Pfizer? We'll just sit tight, formulate your question. I'm going to get the other names, and we'll go in order here. Magda Tobias, Tobias maybe, Ralph Anderson, Matt Ross, and Paul Morrison. So in that order, and I can remind you as we get past the first question, but Tiffany, please start us off.
Hi, Tiffany Pfizer. I guess you're sitting here thinking, I was appalled to learn that private insurers are basically exempt from antitrust in this country. Federal government protects them from having to compete with each other by allowing states government to regulate their prices. How could you possibly justify a free market system that does that?
I'm sorry. I take it that was a question for me, Tiffany.
Yeah.
Okay, and it was, what was the exact question? Again, it was, how can I, what was it?
Well, the debate in this country, the other side against a public option is that the free market should take care of it. Isn't that a lie? The free market isn't taking care of it. Private insurers are exempt from antitrust laws in this country. They don't have to compete for prices. They don't have to compete for a business.
Being exempt from antitrust law, I don't think means that there's no competition. It actually means that they are freer. They're not subject to that regulation. And there are libertarians, I think, who are more sympathetic to antitrust than to other forms of government regulation. But I think that when it comes to state regulation of insurance companies, I think that's where you see the biggest impediments to market competition, and here's why. Each state has decided that in order to sell an insurance policy within its borders, you have to get a license from that state. And unless you have a license from that state that says you have to comply with this long list of regulations, you may not sell health insurance in this state. So whereas you might be able to buy wine from California, you may be able to buy a car from Detroit, you cannot buy a health insurance product from either of those two places because it is not licensed by your state. So that's really a barrier to trade within the United States. I mean, we're supposed to have a great big free trade zone within the United States, and we don't. Now, where that gets to be a problem is when you have those sort of barriers to competition, well, then the special interest groups can go to the state legislatures and they can say, look, you know, you've got this whole list of regulations that people have to satisfy in order to buy and sell insurance in this state. Can you throw in a requirement that they cover chiropractic coverage, or acupuncturist coverage, or contraception, or alcoholism treatment, or in vitro fertilization? States have enacted about 2,000, all 50 states in the District of Columbia have enacted about 2,000 of those individual little laws that require people to buy health insurance that they may not even want. I mean, you've got states requiring teetotalers to buy coverage for alcoholism treatment. Devout Catholics are required to purchase coverage for contraception and in vitro fertilization, which they find morally objectionable. And those things increase the cost of health insurance, and you can't escape those laws by purchasing health insurance in another state because the states have set up those barriers to trade. So I agree with you if your complaint is that we don't have a competitive marketplace, that we do have government imposing impediments to competition, imposing unwanted regulatory costs on consumers, and increasing the number of uninsured, then I definitely agree. We need to get rid of those barriers to trade and have more open competition so consumers can decide what goes into their health insurance policies and more people can afford health insurance.
We're actually going to have a fair amount of agreement on some of these issues because I know from talking to Paul a fair amount about this and being on KUNM with him, we both agree that the current system is not a free market system. There are huge flaws in the system. A lot of them do have to do with what are called state mandates, but there are a lot of other reasons why free markets really don't necessarily work in healthcare. About the mandates, because I think that is an important issue to address, because that's one of maybe the 2 or 3 most common libertarian solutions to the healthcare crisis. Let us shop across state lines. Paul on the radio the other night with Scott Stigler mentioned, hey, I could go find insurance for $1 a month somewhere if I were able to shop in other states, call it insurance, and then I would have my insurance so that I'd meet an individual mandate. But the politicians don't want me to do that. He's right. The politicians he's talking about, mostly in this case Democrats in Washington, don't want you to do that. They don't want you to have $12 a year insurance because frankly it doesn't get you anything. One of the real market flaws related to healthcare is uncertainty. You don't know what you and your family are going to need. There are a heck of a lot of teetotalers who fall off the wagon. Maybe there are a heck of a lot of Catholics. You know, I'm in New Mexico. There are a lot of Catholics who don't wait until they're married to have sex. We have a lot of young single mothers in this state. Beyond that, and those were 2 of the better examples where you could say somebody really truly would never need that, you honestly don't know. Mammograms are one of the mandates in this state. I think we have 37 in the state of New Mexico. There's a reason, and it's more than just sort of well-paid lobbyists, although that certainly helps. But there's a policy reason why mammograms are mandated as part of insurance coverage offered in the state of New Mexico. Our legislators and our people who elected them believe that if you're able to get preventative care, diagnostic treatment, and tackle something like breast cancer early, you will in fact save the entire system a lot of money, you'll save yourself a lot of money, and by the way, you're going to save a life. It's hugely important to have some of these mandates because otherwise what would happen, how many of you, show of hands, I know this is on radio, but show of hands, how many of you have ever read your entire insurance policy? 1, 2, 3. That is, I don't want to question anyone's veracity, that is an unbelievably high number. About 10 people raised their hands out of 90 or so. These insurance policies are unbelievably dense and thick and complicated. And if you don't think that the insurance companies and their lawyers and accountants and claims adjusters know it better than you, you're crazy. I know that's not what anyone said. And I hope everyone should know what's in their coverage, but the truth is people don't. And what a mandate does, it is our way collectively of taking care of an information asymmetry between the insurer and the person buying that insurance, where you know mammograms are covered because your politician campaigned on it. Your state representative did a big press conference. It's the law of the land. And that's an important thing that benefits all of us, even if you personally never need to use it. It's good for driving down the cost of healthcare overall, and it's good for the health of the society. And it's a little bit paternalistic, a lot paternalistic, but it's something that I think most people have figured work. If you ask most people in this state, would you want mammograms to no longer be mandated as part of insurance coverage in New Mexico, I think most of them would say, no, that's one of the good regulations, let's keep that one. Maybe not in this room, but I think around the state that's a popular thing.
Your response?
I think this is an important issue because it's really emblematic of the two approaches that I think that we would take to healthcare reform. Yeah, someone has to, not everybody knows everything that they're going to need. No one knows, no one can predict the future. The question is, which process is going to do the best job of fitting resources, society's resources to society's needs? Is it going to be one where individuals are making these decisions for themselves, or when politicians are making these decisions for us? I think that most people would probably, who want mammogram coverage, would probably buy it. A lot of places where it's not mandated, people still get it. And these, it sort of calls into question the effectiveness of these mandates, the fact that when it comes to mammogram and several other types of cancer screening, there's no discernible difference in screening rates between states that do mandate and states that don't mandate these things. Meanwhile, you do have states forcing people to buy things that they definitely do not want. You also have states mandating coverage for treatments that later turn out to be harmful, such as autologous bone marrow transplantation and high-dose chemotherapy for late-stage breast cancer. Politics makes, the political process makes mistakes too. And in the process, it requires people to buy a lot more coverage that they don't want, and price a lot of people out of health insurance, so they get no protection at all. A good example of this is Massachusetts. Before Massachusetts enacted what I think is really a mirror image of the legislation that the congressional Democrats and President Obama are pushing, it had enacted 40 of these mandated benefit laws. A state commission found that those benefits account for about 12% of the cost of health insurance. So the state has basically required people to pay what ends up being a 14% increase in their premium, whether they like it or not, whether they wanted that coverage or not. So that prices a lot of people out of the market. And since Massachusetts has enacted its own individual employer mandates, those laws have become more attractive to special interests. They've passed another 16 such laws. So when the government decides what's going to be in your health plan, the special interests go at it again. They not only demand these laws, they demand that people buy more coverage with lower cost sharing, which makes the coverage more expensive. And so contrary to everything that we've been told about how the Obama health plan would work, in Massachusetts, the Obama health plan has caused health spending and health premiums to explode. They're growing faster than the national average. They're already high, and they're growing faster than the national average. And it's costing an awful lot to cover the uninsured in Massachusetts. We still haven't even gotten to universal coverage. So I do think that this is emblematic of the two approaches and really highlights how government gets these decisions wrong.
If I could just do a quick response. First of all, I think it's important that everyone realize that a mandate, a state mandate for coverage is very different from a state mandate for treatment. So in the examples, and this guy's a healthcare guru, so I won't even try to say the bone marrow example, but in that example, that's something that a doctor and the patient decided was the best course of action. That's not something that the government or anyone from the state ever decided. That was just something that was covered by their insurance. And as far as Massachusetts, I think we probably will talk about that a little bit more. But there are a couple of really critical differences between Massachusetts and what, for example, 3200 would do. And the main one, frankly, is a public option. What we did was we subsidized a bunch of low-income people, thereby adding to what the market would bear. So the insurance companies now, anytime you have subsidies with for-profit companies then reaping the benefits from that, they're going to jack up their price. They'd be fools not to. The market will bear a higher price. So in Massachusetts, what happened was you had all these subsidies to lower income people, not just the uninsured, but to lower income people generally. And the insurer said, thanks a lot. Now we know what we can charge, and it's an extra 20% above what we thought we were charging before. They don't have a real nonprofit public option to compete against them. And the second thing, frankly, is scale. Scale makes a huge difference in all of this stuff, and I think those are two major differences between Massachusetts and some of the plans being floated on the Hill. We should probably get to that.
Magda?
Yes, right now. Okay, the government currently runs the post office, Medicare, and Social Security. All are currently over budget and need billions of dollars.
Could you stand up? Thank you.
The government currently runs the post office, Medicare, and Social Security. All are over budget and need billions of dollars that are costing taxpayer money. Why would a government-run plan healthcare be any different?
Yeah, I'll take it. No, that's a great question. It's one of the things that you hear people talk about a lot. First of all, people love Medicare, and we can talk about the cost drivers of that in a little bit, because that's a very important point that you bring up. On balance, I will tell you, my dad is lifelong, and he says he's not a Republican, but probably McGovern's the last Democrat he voted for because my mom hated the war so much. But my dad, lifelong pretty conservative guy, had prostate surgery a couple of years ago, and he's doing well. But he had Medicare, and he also had some private retiree insurance. He was a banker. And he said that his experience with Medicare, from getting to pick his own doctor, from the surgery, the treatment afterwards, was so much simpler, so much cleaner, and absolutely effective. This is my dad. You know, he doesn't follow the healthcare debate too closely, and he's not really ideological. He says to me, so we're at Thanksgiving, he says, so has anyone ever thought about Medicare for everybody? I was like, yeah, that's kind of what I do for a living. Yeah, the answers people have. So I think first of all, Medicare, a lot of people are very happy with the way it's run. And it's funny because you'll see at a lot of the town halls people saying, you know, I don't want government touching my health care, and you sure as heck better not touch Medicare. Well, it's a government program. You know, so I think there are cost issues that hopefully will develop later, but I think a lot of people are very happy with Medicare. And surveys show that Medicare is one of the most popular plans that anybody has compared to private insurance in particular. And even the VA, despite the recent controversy in New Mexico, tends to have people who are very satisfied with, again, essentially for that universe, single-payer health care. So I disagree with the premise a little bit that the government doesn't do things well. I think the government does some things very well. I think our military is the best in the world, and we're very efficient at what we do. I think there are any number of things where the government does do well, and there are some that they don't do well. And frankly, I think, and you know, Michael will question my veracity on this, I think things that the private sector can do, and that it's efficient at, we should let them do it. I don't want the government making jeans, or making soda, or selling soda. There are a million things I don't think the government should be doing. But healthcare has so many market failures and so many ways in which the private sector doesn't take care of the needs of our people that I think it's one of the areas where it makes sense to have at least some regulation. And the final thing that sort of goes to your sort of a built-in assumption, we're not talking about single payer. We're not talking about public control of the delivery system. I haven't seen, even among single payer advocates, really any serious proposals to have the government employ all of the healthcare workers. This is, frankly, in a lot of ways, very incremental change. The biggest change probably in this bill is guaranteed issue, that everyone gets covered no matter how sick they are, and the insurance, whether it's private or public, can't kick people off. But the thing being discussed, the most progressive thing realistically being discussed in Washington right now, is merely to have an option that has to play by the same rules. It's not going to be like Medicare where there's a tax base backing it up. They actually even have to pay back their initial startup costs over the first 10 years. Well, you know, people always say read the bill. That's what's in the bill. And so you can laugh.
Focus on the cost. She asked a question about cost.
Well, but I think it's important to realize that we're not talking about a government takeover of healthcare. This is very incremental, and we're talking about one option. That's really the only government involvement in this, and then having some requirements that basically the big requirement is that insurance companies can't kick people off if they get sick.
Okay, Michael?
Medicare is popular among Medicare beneficiaries mostly because it's so wasteful, mostly because Medicare just throws money at anything. Medicare is not a very discerning purchaser of medical services. It's interesting that Carter brought up prostate cancer, because there's a lot of evidence that suggests that a lot of what doctors do to fight prostate cancer does absolutely nothing to help to improve outcomes. And a more rational purchaser would not do that, but when you get a doctor and a patient together, the doctor says, I think this will help you, and the patient says, okay, I want that, and Medicare says, yeah, we'll pay for it. Well, of course that's going to be popular. And so I don't think that is a Medicare popularity in that regard is evidence of its success. I think that's evidence of a failing, that it's not really looking out for the taxpayers. I mean, Medicare is required, if you want to, I know that it is promised that a new government option will be self-sustaining. It was also promised that Medicare would, Medicare physician insurance would be 50% self-sustaining, and now it's only 25% self-sustaining because Congress has incentives to make it less self-sustaining over time. The program, I figured I would address another aspect of the cost question of Medicare, because I definitely agree with your premise that these programs do bleed lots of money. And so one of the interesting ways that dynamic has cropped up in this debate is that supporters of a new government option have talked about this vice of Medicare as though it was a virtue. Medicare is not a very prudent purchaser, doesn't spend a lot of resources on administrative activities to figure out are these people over here defrauding us, or are these services actually providing any benefit to patients? And because it avoids all those administrative expenditures, those administrative activities, well, its administrative spending as a share of claims is very low. It's about 3%. So people say, yay, go Medicare. That's evidence that Medicare is efficient. Actually, that's evidence that Medicare is horribly inefficient. And that's not even all of, and when you then include all of Medicare's administrative costs, in addition to the fact that it's not undertaking administrative expenditures as it should be, expenditures on behalf of Medicare by other federal agencies, the Department of Justice and so forth, that support the program, bring administrative spending related to Medicare up to 6% of Medicare claims. But then when you consider the fact that Medicare is financed by taxes, and Medicare, and that taxes reduce economic activity through what Ken Elzinga might have taught us was called the deadweight loss taxation, the actual cost, administrative costs of Medicare are multiples of the administrative costs of private insurance, which have been clocked on average in the range of 12%. For Medicare, it can be 30%, 50% of claims. So this is actually a very inefficient program. The main reason it's attractive, and why Medicaid is attractive and a new government option is attractive, is that these programs hide their costs. They don't have lower costs, they just have lower apparent costs. And it's because they hide those costs that they appear more efficient.
One of the nice things about having a debate with someone from Cato is that there's not all that much dispute over the facts. So we get to really talk about philosophy and how you see things and spin things. It absolutely is true that it is probably easier to defraud someone like Medicare than it is to defraud a private insurer, because private insurers spend a huge percentage of your premium dollar trying to deny claims. So if you spend your entire life trying to deny both good and bad claims, you're probably going to weed out more of the bad claims. If I am a consumer of that product, and I'm a legitimate good faith, like I assume everyone in this room would be, consumer, I want the person who's actually going to get me my coverage fair and square that I've been paying into for my entire life, than somebody who's going to deny me that coverage. It's very important to realize that all those administrative costs in the private sector, yeah, some of it goes to fighting fraud, but a lot of it goes to denying legitimate claims, or doing a little bit of research to find out that even though you checked that you're non-tobacco when you applied, well, there are pictures of you on Facebook from 10 years ago when you were smoking a cigarette in college, and they'll deny your claim based on it. So, it really depends on how you look at it, what your frame is, whether having low administrative costs is a good or a bad thing. I think most people would say it's a good thing. As far as the deadweight loss of taxes, which was in one of his articles, this guy's really well written, and he's a terrific writer. It's not that dissimilar.
Can we give him more time?
It's really not that dissimilar from premiums. So I think it's fair to say that yes, there are opportunity costs by the fact that you're paying, essentially everyone's forced into paying premiums into Medicare. But if you're going to do that analysis, I think you also have to say that people pay premiums into private insurance as well, and that money could have been used for other sectors of society.
response?
Well, that's not, the definition of a deadweight economic loss is money that was, or economic activity that was never generated. There is an opportunity cost to it, but it's not a resource that you spend here that you could have spent someplace else. It's a resource that never came into existence because of the presence of taxes. So it's a little different from premiums in that.
Okay. Ralph Anderson.
I've got a question that pertains to the quantity of people who are insured, who are not insured. I hear all sorts of statistics about the percentage of people in the state as well as the country who are not insured. And I see other stats that tell me that of the state of New Mexico, around 20–25% are uninsured. Nationally, it's around 16, 17, 18, 19, whatever that number is. But I'm led to believe a lot of those that are not insured have opportunities to be insured but elect not to. There's a group that's thinks they're going to be invincible, they don't need it. We got people that don't know enough. So would you talk about that issue, break that down into segments, and would you also talk about the quality of the various kinds of insurance, the more richer ones, the less richer ones, Medicaid and so on like that?
That's a lot. Let me see if I can tackle the question about how many uninsured there are in the United States. It really depends on how you define uninsured, because you have to define it in terms of a period of time. Were you uninsured? Are you uninsured today? Were you uninsured for all of last year? Were you uninsured for 2 years? A 2-year stretch. If you look at all the people who are uninsured today, it's a bigger number than all the people who are uninsured for all of last year, which is a bigger number than all people who are uninsured for a 2-year stretch, about 2 years. So the number that is most often cited, it's funny, the number that's most often cited is 46 million Americans lack health insurance. That is supposed to be a measure of how many people were uninsured all of last year. But the experts think actually what the survey ends up measuring, even though it doesn't try, it tries to measure last year, it ends up measuring how many people are uninsured on the day they took the survey. People just look at their existing insurance status and they report that as their status for all of last year. So 46 million, a lot of those are temporarily uninsured. If you look at there have been estimates of the number of people who are uninsured for an entire year, and I think that was 20 to 30 million. But if you look at that 46 million figure, a lot of interesting things emerge when you start picking it apart. One of them is that as many as a fifth to a quarter of those people are actually eligible for an existing government program, health insurance program. So that if they walked into a doctor's office that accepted Medicaid or S-CHIP or a state program, they would be able to get medical care. They would be able to enroll right there and get medical care. If they go into the emergency room, then they are enrolled unless they decline. So that's about a quarter. I think one of the more interesting studies that have been done on the uninsured was done by professors from the University of Pennsylvania and Stanford that compared the uninsured to similarly situated people who have health insurance, similar age, socioeconomic status, and so forth. And just by virtue of and self-reported health status, just by virtue of the fact that by pairing those people up and comparing the uninsured to people who seem to be like them, they estimated that anywhere from a quarter to 3/4 of the uninsured, of that 46 million, could afford health insurance if they wanted to purchase it, but choose not to purchase it. Now that I think is fascinating to me. I think that's what we should call a market signal, that these people are sending us a message that there is something horribly inefficient about this system, that they think health insurance is not a good deal for them, and they're choosing not to purchase it. Now, why might that be? Well, you said, you brought up one reason, that they might think that they're invincible, and you can't work in health policy for too long without hearing someone inveigh against the young invincibles, just looking down their noses at all those young people on their skateboards and doing all those young people things. They're going to end up in the emergency room, we just know it, and darn them what if they buy health insurance. And, you know, I was a young invincible once. I mean, I had health insurance, but I didn't think I was going to die or anything was going to go wrong with me. So I understand that, but you have to understand all the things that we've done to make health insurance unaffordable and unattractive to these people. I mean, employer-sponsored health insurance is supposed to charge everyone the same premium, even though they cost dramatically different amounts to insure. So a young person who is offered a job from one employer that offers health insurance, but a lower salary, and another employer who offers a higher salary, well, you know, they don't value the health insurance as much as the wage hit they're going to take, so they'll take the job from the other insurer, or the other employer. A lot of states want to have laws in place to try to tax young people in order to subsidize the premiums of older people who, by the way, usually have more money. And that's exactly what the Obama plan wants to do. It wants to almost completely eliminate any risk rating of health insurance premiums in an effort to tax the young people in order to subsidize older people. And that is, I think, those are, I think, the main reasons why so many young and healthy people avoid purchasing health insurance, because we've driven them out of
And
the
who's this professor and,
Mark Pauley of the University of Pennsylvania and Kate Bundorf of Stanford University.
oh, okay.
I can give you those afterward if you.
With that, I'm going to get Carter's take on this.
Yeah, again, I think there's a lot of agreement on what's going on here. There are a lot of those, we always hear 47 million recently, so 46 or 47 million people, a lot of them could qualify for public programs. I like that the Cato Institute is now promoting public programs. But that, you know, this brings up one of the most important parts of healthcare reform, one of the most important parts of 3200 and all the other bills that are going on. It's something called an individual mandate. And again, some of this is just a philosophical disagreement. Do young, healthy people subsidize older, sicker people? Yeah, that's what insurance is. That's what pooling is. If you really charge premiums based on how sick people were, the sick people could never afford it. I mean, 2% of the population maybe. Sick people can never afford it. What an individual mandate does, what requiring people to purchase more than their actuarial value of insurance is, which is what we're asking the younger and wealthier people. There's Medicaid for the very poor, and 3,200 in the other bills have a sliding scale for people all the way up to 400% of federal poverty level. If you think about what the impact is on the system of having people pay in their whole lives, it's incredibly powerful because it does two things. First of all, some of those young invincibles do get sick. I lost a very good friend when I was a teenager to brain cancer, and my best friend from law school's wife died of breast cancer like 6 years ago. She was only 35 at the time. It happens. It does actually happen. And they both had great insurance, but the people who don't, that's a huge, it does one of two things. Either it's a massive burden on the people, all of us in this room who pay premiums, and all of us in this room who are taxpayers. We end up picking up whatever the cost of treatment is, or they end up getting poor treatment and die a lot younger than they otherwise would have. So for young people, it is a little bit paternalistic to say, yeah, you've got a chance of being sick too, but it's important to have that for them. The second thing is, think about it this way. If I am 41 years old, and let's be dark and talk about end of life. Let's say between now and the time I'm 84 when I die, I have 2 really high health cost years. When I'm 70, I have something happen, and then I make it to 84, and my last year is an expensive one. I could go the rest of my life being pretty healthy and not paying in and all that. And if I know that somehow I'm getting picked up by taxpayers or other premium payers, what's my incentive to put anything in myself? What an individual mandate does is it allows me to pay in, it forces me to pay in for 43 years until I die to cover 2 really bad sick years. And a lot of the time that'll cover it. So a mandate, basically, yeah, having younger, healthier people pay a little bit more than what the actuarial value of what they're getting is. It spreads the cost of healthcare across a larger pool of people, and it spreads it across a greater span of time. So again, I think it really depends how you look at it. Are we really just looking at insurance to purely be a way of purely allocating risk? I don't think we are, because almost everybody gets sick at some point, and you want to have that coverage, and you want to be able to afford it when you do get sick.
Quick response, Bill. Okay. Matt Ross.
So I guess it's a question that you'll both address, but to the gentleman from the Cato Institute, as a consumer in the modern world, I can't possibly research, let's say, every chemical that they put in the can of soda or in the bottle of water, or everything that they use to build the computer that I'm buying. Or across all industries, mandates exist to protect consumers who can't figure all that stuff out on their own, and don't have the time and don't have the resources. And yet, I can still buy a good can of soda for a good price. I can still find a valuable computer at a price that I can afford. But that's failed in the insurance industry. We have nothing but skyrocketing prices, millions of people don't even have access to coverage, and millions of people who pay in good faith for a product are denied access to that product. So even though all of these industries across America are operating within a system of mandates and still making a profit and still providing a good product, they can't do it in the insurance company. Won't a public option force those people to compete with a truly quality insurance plan that is affordable to millions of Americans?
If the question is about, you raise a lot of topics. The question is specifically about a government option competing with private insurance.
I think I have two basic questions. Is why is there a difference between those insurance companies that can't seem to make a profit without providing a terrible product by most people's definition? And as the first question, and as the second question, won't a public option force them to really compete?
I think that it's too often unchallenged to claim that private health insurance is awful and just leaves millions of people out in the cold. Now, I think that there are, whenever you have one party making a commitment to another party, there's always the possibility that that first party could renege on the commitment. And it's really abhorrent when we see that happening in health insurance, because that, party B is in dire straits over here. Not all claims of reneging are actually reneging on that commitment, and so and sometimes people, party B did defraud the insurance company and lied on their application, and so so the question is, how do we get them to make these binding commitments in ways where no one's defrauding anyone else? And it turns out, and I think this is an unexplored area of our healthcare sector, and this healthcare debate that needs to be explored more fully, which is what actually goes on in these in what we call the individual health insurance market, where people buy health insurance directly from the insurance company. It turns out that they get an awful lot of protection against a lot of things. The increase, the threat that their premiums will go up if they get a high-cost illness. The market erased by itself. Because it developed a product called guaranteed renewability. I can discuss what that means, but what it means is if you get diabetes, your premiums don't go up to reflect that. They go up the same amount as everyone else's. That's a form of protection against a very important risk that you'll face a higher premium. They also provide more secure coverage than employer-sponsored insurance. If you have insurance through the individual market, you are half as likely to end up uninsured compared to people with insurance through a small employer, and that's people with high-cost conditions. So people who have who purchased insurance through a relatively less regulated market have more secure coverage than in a more regulated market. Now, the question about a government option competing with private insurance, I've said before, and I'll say it again, that if you could have the government competing with private insurance on a level playing field, meaning the government options premiums reflect its actual costs, no hidden costs, reflect all its total costs, and private insurance premiums reflect only their actual costs. In other words, the government isn't loading additional taxes or costs on private insurance to cripple their competitors. I don't think consumers would have anything to fear. I think market competition would sort out whether government or private insurance does a better job. The problem is that that precondition of a level playing field is impossible to meet. And I don't mean, oh gosh, it'd be really hard, but if you did it this way, it would be impossible to meet that precondition. And the reason is, well, I'll give you one reason. The government, the government program, if it set its premiums below its actual costs, could undercut private insurance that way, and would probably get bailed out by Congress. Probably would. I mean, Congress kind of does that when it comes to Amtrak, when it comes to the post office, and so forth. And now you can say, read the bill, and it'll say that no, this has to be self-sustaining. But here's what's important: even if everyone in this room believes, and everyone in Congress believes, that no future Congress will bail out the government program, what matters is what the market believes. Because whether the market believes that Congress will actually let its own program fail is going to determine the interest rates, for example, that lenders charge that program when it needs to borrow money. With Fannie Mae and Freddie Mac, there was no explicit guarantee of a bailout. And yet, Larry Summers, President Obama's, well, he was then President Clinton's economic advisor over the Treasury Department, he's now one of the Obama's top economic advisors, wrote a report, or signed a report, where he said, yeah, actually that implicit guarantee of a bailout saved Fannie and Freddie about $6 billion a year. So it's unless you can convince me, and I'm open-minded on this, unless you can convince me that the Congress could do something to convince the entire market that Congress will never bail out its own program, then you're not going to get a level playing field. And the problem with that is that government programs actually provide an inferior product to private insurance for a lot of reasons that I'm happy to go into. And therefore, what you would have is you would have government program undercutting private insurance, pulling people out of private health plans. Private insurance would wither on the line, and it would do all of that while still offering an inferior product. And I think that's something to be very concerned about.
Carter.
I think one of the problems of analyzing can it be a level playing field that I really haven't heard people talk about is I think if anything, the playing field could end up being skewed against a public option, because the public option is going to be under a microscope. There's going to be a lot of pressure. Let's assume the guaranteed issue gets in here, which is, like I said, really a cornerstone of the whole bill. The public option is going to have some little form that you fill out and name Social Security, a little bit of medical history, and you're in. The private insurance company, if I were a private insurance CEO, you always have to think, what is their incentive? And their incentive is to take care of their shareholders. I mean, they love everyone. I don't think they're bad people. They love everyone to be healthy and get good care, but their first priority is to make their shareholders whole and to get a good return for them. So if I'm the private insurance company, I'm going to take that application and say, so glad you're here. Sorry about your previous bout with cancer, but guaranteed issue, we're going to take care of you. If you could just now get us the medical records from your parents, grandparents, and original birth certificates from each one of them, that way we can serve you better. What I would do is I would intentionally throw up little roadblocks, little administrative roadblocks to push the sicker people into the public option. It's a real problem, adverse selection for the public option that I think actually, in some ways, I'm a little bit scared of the public option because it's going to look less efficient unless they really, really go after these private insurance companies to make sure that it's a clean, easy process to sign up. So I think there probably are concerns, and Michael brought up some good ones about things that could potentially benefit a public option plan, but I think there are things that the private insurance company, they're not going to micromanage their administrative process. So I think there are things that the private insurance companies are going to be able to do to give themselves a little bit of an advantage. I think the competition point is a really good one, and I also want to say that I'm open to one of the classic libertarian ideas about cross-state shopping if you had something like what's in this bill, which is some kind of national base standard for what has to be included. I think you would open up the market to more people being able to purchase more products across state lines if you had some kind of national baseline. Now, I know Congressman Heinrich in his town hall, some of you were there, part of the problem with that is you're now fighting the insurance commissioners of 50 states, the governors in House and Senate in 50 states, well, 49, Nebraska's unicameral, right? But you're really talking about a huge political battle to have some kind of federal standard about what the mandates are, because most people agree there should be some mandates. I mean, again, libertarians might not, but most people think there should be some. So as a practical matter, if you were able to create that kind of national floor, I think cross-state shopping would be a good way to address one of Matt's issues about creating more competition. The final thing is the government product an inferior product? All they're doing, all any of these guys are doing, is being a middleman. And I think you have to look at the incentive to determine whether a private insurance company is a more efficient, superior, better middleman than a government. That the government opens itself up to fraud by being more likely to say, yeah, that looks good to us, you're good. But it depends how you define inferior and superior, because I think there's a real inferiority to having 30% of your overhead going to basically lawyers, accountants, and claims adjusters who are graded by the insurance companies on how effectively they're able to deny claims, because every claim you deny is more dollars straight to the shareholder's pocket. So I think it's an open question as to whether that's an inferior or superior product.
Carter, what was the caveat on Nebraska again?
Oh, it's a unicameral legislator.
They only have one house.
Yeah, it's, yeah.
He's just staying in the geek.
My mom went to the University of Nebraska. I can't forget about Nebraska. So.
Mike, would you have
Well,
anything on that? No?
I'll just voice my aspiration that we'll get a question directly about guaranteed issue or our community rating.
Well, it falls to Paul Morrison to ask whatever he wants.
Paul can ask whatever he wants.
Part of my original question has already been answered, or was talked about. But I have to take exception first to comments about insurance companies being graded by how much they can decline. I worked in insurance for many years and retired from insurance. They're graded more on how fair you settle a claim. Because there is such a thing as bad faith lawsuits against insurance companies who deny the claim unjustly. So I think you're wrong on that point. But anyway, this whole health care thing started out talking about the so-called 47 million. Of them, I think a small fraction were really uninsured, couldn't get insurance, or too poor for it. How did it blow up to this whole thing to include 304 million people? And finally, is a national health plan constitutional? Would it fit a constitutional test based on how the Constitution was written, not how our crummy courts are today who allow everything?
Sure. Well, why don't I take the last one first about the lawsuits and the constitutional one. You know, it's a good question. What are the limits of Congress and the federal government? And it's true that the Constitution doesn't say you can regulate health care, but the clause that has been, I took a lot of con law, and the clause that used to be untrammeled, that where Congress was taking over everything, it's called the Interstate Commerce Clause. There's a 1995 case called U.S. v. Lopez that was about the Gun-Free School Zone Act, where for the first time in, I think, 70-something years, since 1928 maybe, the U.S. Supreme Court, in a Scalia opinion 5-4, ruled that, in fact, there were limits to what Congress could regulate, and because this was merely about possession of firearms near a school district, which are almost entirely, obviously, within a state's boundaries, because of that, there was no commerce, it was just possession, and there was nothing interstate about it. And on a 5-4 basis, U.S. v. Lopez really was the first brakes ever put on the Interstate Commerce Clause. It's a good question. Republicans control the Supreme Court. They control pretty much all of the courts of appeals except for maybe the ninth. Well, I mean, look, 20 of the last 28 years there have been Republican presidents, and I think some of them less conservative than others. I think George Bush gets bashed by both sides, right? So people don't necessarily trust his appointees. The second, and actually David Souter was a Bush appointment, so you can't always judge based on that. But it is a predominantly Republican judiciary at all levels of the federal judiciary right now. I mean, statistically it is. And so we'll find out. And there are plenty of
rhinos.
Huh?
They're only rhinos.
They may be rhinos. You may be right about that. But that's who's in our judiciary right now. And I'm sure that the very capable lawyers at the Cato Institute and ACLJ, I think it is, there's no shortage of conservative think tanks and advocacy groups that will challenge this law. I will say that because there's so much commerce involved and because it affects the national economy, my guess is based on previous court jurisprudence, it would be upheld as constitutional. And your other comment about lawsuits, I don't want to be unfair to the insurance companies. Look, I know there are a lot of very good people who work for them, but the economic incentive is clearly to deny as many claims as possible. In a brief story that I went through, I'm a pasty white guy in New Mexico and I don't use enough sunblock, so I'm always careful to get checked for little moles and things. So my doctor suggested, at St. Joe's, he suggested that I get a little biopsy. So they scoop out a little thing and they send it off and it was benign. $600 bill, not a big thing. It took me a year. And I have a job where I can make long distance calls and I can take 20 or 30 minutes in the middle of the day to fight this. It took me a year to get them to finally say, like, oh yeah, of course that's covered. But what they did was they blocked me out. And to a lot of us who aren't on the inside, it looks a lot like you say no the first time and 80% of people are never even going to question it. In their minds they'll question it, but they're not going to know that they can really challenge it and battle it. I probably put in 20 hours worth of work over the course of a year for $540. Was that a good use of my time or the insurance companies? Probably not, but I think as unfair as it is to say that they're bad faith, and I really don't want to say that they're bad faith, they clearly have an economic incentive to shut out certainly any close calls. So I think that's where that comes from. It's not meant as a personal attack on anyone in the insurance industry.
The Constitution may not be perfect, but it's better than what we've got.
All right, 5 new names here. These may be the last folks. We have long, like aside from that last one, they're very informed individuals, and so they have detailed answers. But first is Jace Hanrahan or Harrison or something like that. Do we have Jace, J-A-Y-C-E?
Oh, it's Joyce.
Joyce, okay.
It feels like Price is Right, doesn't it?
You should be a doctor, your handwriting. Okay, you'll be the first one out of the chute. Josh Anderson, Barbara Cheney, Ted Cloak, and Mackenzie Bishop are on deck. So Joyce, give us your,
I guess I'm.
stand up please.
I guess I'm a cynic, but I'm kind of a believer that a camel is really a horse that's put together by a government committee, not against government bureaucracy. But what worries me is what I'm following up with this lady's question of cost. We look at all the government from Medicare on down and FEMA, and we say to ourselves, they're all going bankrupt. Senator Baucus, who's the Democratic senator who is shuffling the Obama bill through the Senate, said that Medicare will probably go bankrupt in 2 years, which is amazing. How in the world can we ever finance a public system like this that they want to get through Congress? I don't see it. I don't see it with China sitting on our treasury notes. I don't see it with the deficit we have. I don't see it with a insurance or with a finance plan that's going to be $2 trillion for health.
Okay, I think we get
I
that.
haven't heard any answer to the cost on this part of it.
Well, the first way we're going to pay for it is we're going to hide the cost as best we can, so you don't realize how expensive it is. And there are a number of ways that they're trying to do that. If you want to come even close to providing universal health insurance coverage in the United States, and that is the motivation, I think, behind this legislation, is the only goal that really explains why it looks the way it does. It's not about cost control. The CBO said it's not going to control costs. It's about trying to expand coverage. To do that, it's going to cost, over the next 10 years, about $2 trillion. $2 trillion. Now you hear people say, well, it's only going to be 1.6 in this bill, it's only going to be 900 billion in, only 900 billion in the bill that the Senate Finance Committee puts together. The way they're making that number look smaller is by saying, well, maybe they're looking at a 10-year window. Well, maybe if we don't start the program until the second 5 years of that 10-year window, then it'll make the program look like it's half as expensive as it actually is. They have all sorts of other mechanisms. They push much of the cost off of the government budgets by mandating that you spend your own money rather than collecting it from you and then spending it on your behalf. And so that's the first way that they're going to pay for it. But the other way is they're going to have to raise taxes, and then they're going to have to start denying services to people. Now, about taxes, even if Congress did nothing on health care this year. The Congressional Budget Office has estimated that by mid-century, just to pay for the existing commitments that the federal government has made, and this is mostly because of Medicare and Medicaid, where the real cost drivers, just to pay for its existing current law commitments, through income taxes, you would have to basically double income tax rates by mid-century. So the highest individual income tax rate would be 66%. If you want to expand health insurance coverage to more people, if you want to create a new government program, it's going to be even higher than that. So it's my sense that the American public is not going to tolerate tax rates that high, much less higher. And so Congress will keep raising taxes until they hit a wall. They'll keep borrowing money until the Chinese stop buying our treasury bills. And at that point, the Congress is going to have to start saying no to particular services. It's going to have to start rationing care. It already has the power to do that. It doesn't exercise it very much because it's been able to get away with it because Americans have this revulsion to the idea of the government saying that you are not worth this service, even though we wouldn't spend our own money on that service if in many cases, we have no problem spending someone else's money on it. So I don't want to be too alarmist about government rationing. I think that it might not overall do any harm to health outcomes in the United States, but it's certainly something that at least a vocal minority of the public has let us know that they're not going to tolerate. They don't want the government to be making those decisions. And I think that's the answer to your question. Hiding the cost as much as they can, but then when it comes to raising taxes and denying services to people.
So I love your first analogy that camel is just a horse by government committee. If you live in the desert, camel's a pretty good animal. It's not a bad thing to have at all. So I think that goes back to the idea that some things are better suited for government design than others. This isn't a public system that's being talked about in here. There are significant, again, the guaranteed issue is the big one. There are significant new government regulations, basically, that insurance companies can't kick people off that will drive health costs. I mean, but right now, what happens is they either get treated and the taxpayer pays for it anyhow, or they don't get the treatment. And I think most of us who have insurance would like to get treated if we get sick, since that's kind of what we're hoping for. But you raise a great point. The projections on Medicare and Medicaid are terrible, but you know what else is terrible? The projections on the current healthcare system overall. Right now it's 18% of our gross domestic product. By 2040 they're talking about it being 34, 35%. This is out of control. It's not just Medicare, it's not Medicaid, it's not government, it's not VA. It is all of our healthcare costs. And one of the things we have to get serious about as a country, and this is society, this is every person in this room, we have to get serious about how we spend our money. It means cracking down on fraud in the government programs. It means eliminating overuse of high-tech equipment when it's not really necessary in both private and public sector. It means prevention and wellness programs. And one good thing about this bill is it greatly incents people to start doing more prevention and wellness. That's an important factor that I think is a common sense solution to a lot of our costs. But eventually, even if you stay healthy, something catches up with you, right? So you don't die of diabetes or being overweight, something else catches up with you maybe 5 years later, right? So even wellness and prevention isn't a silver bullet. But there are a lot of things that we have to get serious about. Pharmaceutical drugs. Tort reform. I'll tell you something. That tort reform, not just in the classic way people think about caps, because in the states that have put serious caps on, like Texas, 250,000, their medical liability has actually gone up faster than other states. So caps on damages isn't necessarily. Who asked that question? Who mentioned that?
Oh, it wasn't a question.
Yeah. No, it's just yeah. So, but the point is, caps haven't really worked in Texas or Florida or some other places. California even has serious caps. What I do think needs to happen is we need to create some kind of certainty for our medical providers, for our doctors, nurse practitioners, for the hospitals, where they know at the time if they make good decisions based on what they see coming in the door in terms of diagnosis and then how they treat that person. If they make reasonable decisions at the time without recklessness or gross negligence, that they're going to have some level of protection, because defensive medicine is a major driver of our healthcare costs. And we have to get serious about saying that if you do the right thing and you're a provider, you're not going to be second guessed because later on it happened that some hidden thing was going on that there's no way anyone at the time could have seen. So I agree. We need to seriously look at things like tort reform. Everybody in this society has to get serious about cost containment. It's not a Medicare or Medicaid thing. It's our entire health system. It's out of control when you're seeing 10, 12, 15% increases in your insurance premiums every year. It's not just the public system. So thank you for the question. We have to do this. It's a lot of different prongs. Pharmaceutical industry. We passed Medicare D. 218 Republicans, not one Democrat, passed Medicare D. And they included in there, Billy Towson was now the lobbyist for pharma, included in there no negotiations. We locked ourselves in as a country to paying the highest prices in the world. And it's one of the things Michael says. It's a problem with sometimes doing things through the political process, because pharma dumped a ton of money throughout the last 10 years leading up to 2006 into making sure that we would pay we pay out prices for Medicare, which is doling out tens of billions of pills a year, maybe hundreds of billions of pills a year. We pay as if each person was walking in the door, buying, negotiating for their lonesome. That is ridiculous. That's not a market. That is a huge rent. It's a huge ripoff by the pharmaceutical industry. Now that's not in this bill, although President Obama did get a concession of about $110 billion over 10 years. But I think, look, that was a political decision. We couldn't take on, nobody could take on the trial lawyers and pharma at the same time. They're only human. So those got left out, frankly. It's a political answer. But I think you're going to see something happen on both of those, and I completely agree that something has to happen on both of those.
Carter, just a short question, because I've heard this, and lots going pretty fast in Texas, and it's always referenced to Texas. The personal injury cap settlements in the state of Texas has not driven down malpractice insurance rates to the healthcare providers?
That is what I've read, yes. That it's still incredibly expensive to get medical malpractice liability insurance in Texas.
So PI settlements and cap settlements that have been very aggressive in Texas and California has not reduced malpractice insurance for the healthcare providers, and therefore has not driven down the price of healthcare delivery.
That part of the cost hasn't been driven down, and there are a lot of
Because
reasons
I
for
hear
it.
that a lot, so
Yeah. No, there are a lot of reasons for it, because you can start to sue every single doctor in the hospital, and there are a lot of reasons that, and the lawyers are creative too, right? They come up with a lot of things. So, and frankly, look, if you lost a kid due to true negligence, I think you would want to have the right to sue. So, caps may be part of it, but that's not the silver bullet in this. I think we need to do something that deals with defensive medicine.
But oftentimes,
Hold on. We're going to kick the ball over to Michael. We don't want to get to protocol.
I'm all about this med mal in my head. What was the original question?
I was about cost, and somebody said tort
oh,
reform is
oh,
part of
okay.
cost.
Yeah,
Yeah.
it was what we saw Joyce's question, and I had it.
Okay. Josh Anderson.
All right, well, I want to thank you guys. This has been a pretty good debate so far. I have a pretty simple question. I'm all about choices. I'm not the type of person that says the insurance industries need to go. I'm not the type of person that says the public option is the best thing on the planet. We have a lot of people that choose public over private education. We have a lot of people that choose to go work in the public sector over the private sector. Those options are out there. We have this event tonight. We could have had it at a private hotel, but we're having it in a public building. Simple things like that. Taking away the boogie story, the boogeyman, the good, the bad of the issue. If someone is not happy with their private insurance, how does it give us the right to tell them that they cannot have a public option? I think there's a lot of members of this society that would like to have their insurance run through a public, government-run insurance program. If we have a large segment of society that want to do that, who are we to say that they can't have that option? Who are we to say that they can only have a private insurance option?
I'm sorry.
My name's Josh.
Josh, I want to make sure I wasn't cutting you off.
No, that's pretty much it.
I want to disagree with you and agree with you. I disagree with you in that I don't think that anyone really has a right, as you say, to have that choice, because what you're talking about creating, when you're talking about creating a government option, is you're talking about giving the government more power over each and every one of us to take our tax dollars and spend it on something, and maybe it's only startup costs. But even if it's just startup costs, I think we all have a say in whether or not the government spends our tax dollars that way. And I think there are a lot of valid objections to not just spending those tax dollars that way, but for the very idea, of a new government program. But you raise, I want to agree with you in that I think that if proponents of a new government option think that it can operate on a level playing field with private insurers, and that it can outperform private insurers, there's nothing stopping those supporters from going out and starting a health insurance plan on their own and administering it, just like they want the government to administer a new government option. All they have to do is raise the seed capital. And really, if you're going to be undertaking such an enormous venture, shouldn't you have to convince the people whose money you're gonna be spending that it's a worthwhile venture? And if you can't, what does that mean? If you can't get people to invest in that, what does that mean?
That is not a good plan.
Well, and that's, so I say, right on if you want to give people that choice, the choice of a program that's operated exactly like they want it to be operated in HR 3200, but just don't make it coercive. Don't compel people to participate in something they don't want to participate in by, taking their tax dollars to fund it privately. By all means, go ahead and start that sort of plan, give people that option.
But my whole point was there's a lot of people that do not trust the private sector. And if the public option, outside of the seed money, and the way I understand the bill, that it's gonna be funded through the premiums that are gonna be paid by the folks, it's not gonna be a huge tax increase on every other American. We can debate on it. But if the issue is outside of the seed money that's gonna be used to plan it, it's gonna be paid for by premiums of the folks that actually purchase the plan. If that's the case, there are a lot of people that would want to go through a public option. They trust it more, whatnot. Maybe they've been burdened in the private sector, maybe they've been dropped from a plan and they can't pick it up anywhere else, but the public sector will accept them. Again, I don't want to say public option is the greatest thing, I don't think it's the worst thing. All I'm saying is, if it's gonna be funded by premiums for people that wanna be part of it, and it is something that's folks, that obviously large segment of society that want it.
Okay, we've got the
Why-
question. Hold on. Let me part your choice.
Why can't we give folks that option? There's some people just don't want to be part of the private sector.
Would you agree with me, though, that the people who object to having because a lot of people don't want, a lot of people mistrust government the way a lot of people mistrust private insurance. Would you say that the people whose tax dollars would be spent on those startup costs should have a say in whether or not their tax dollars go to that sort of thing? I mean, we agree on that, right?
Well, I think that's what happens when you elect people to Congress and Senate and President of the United States is people spoke and they.
Right, sometimes you
people
get overrated,
campaign on-
sometimes your preferences get
Yes,
steamrolled, but you at least have a say, right?
But we can't, 100% of society is not gonna agree on everything. If that were the case, then nothing would ever get done.
And let me end with this and then I'll turn it over to Bert. And I think that's the great benefit of an economy that's based on voluntary exchange, is that individuals' preferences less often get steamrolled by others who have different preferences, because you control your money, you control your own decisions, and you don't have people usurping your money, your decisions, and using those resources in ways that you would prefer they not.
This is kind of fun. This is a classic discussion about what is the role of government and what are the role of taxes and why do we elect people. Yeah, even if you just say, even if you assume what's in the bill is going to happen, that the startup costs are repaid, you know it's going to be at a low interest rate, right? It's the government basically loaning money to a bunch of people paying a premium. So there is, everybody in this country who pays taxes is going to be helping start this thing up. But we do that all the time. We started the interstate highway system under Dwight Eisenhower, and I think most people would say that even though private capital didn't go out and purchase all that land, and well, they didn't have powers of eminent domain too, but they could have, at that time certainly purchased a lot of the interstate highway system land. And since the government is supposed to pay fair market value for eminent domain, which they don't always do, but basically it's within, it's certainly within, one order of magnitude of what it would have cost for the private sector to get all that land. The private sector didn't come up with all that capital to create an interstate highway system. And I think most of us would agree that that's been a boon to our entire economy, including the private sector. There are certain infrastructure and other kinds of activities that by pooling our money together, and like I said, this all gets refunded. This isn't like Medicare where it's mandatory, permanent revenue increase, revenue source for this plan. This is something where it's going to be paid back, and we all trust government to different degrees, but this is what's in the bill. You can't say, well, did you read the bill, and then say, yeah, and this is what it says. So, look, I think it's a really valid question. I wasn't especially enamored of our going into Iraq. My tax dollars paid for us to go into what I think has still, by and large, been a very wasteful war. We elect people in Washington to say, yes, spend money on this, no, don't spend money on that. And I assume y'all elect people or vote for people who are against things like funding healthcare, but there are other people who say that's something that collectively we ought to be investing in. And in this case, since it's not even really, the money isn't even staying with that new system, I think it's a fairly meager thing to include in the bill. I gotta tell you, progressives think this is the most watered down, weak piece of legislation imaginable. They do. I mean, progressives really do. I mean, you don't have to like them. I mean, they really do. So, you know, again, I think we've made decisions in the past about how we spend our tax dollars that are a lot bigger and bolder than this particular endeavor. And, you know, it's a good question. That's what democracy is about, and that's why we have elections.
Michael, you got anything to that? Okay.
I just had a question.
Well,
Is it burning out? Is
No,
Congress
we got Barbara Cheney. Sorry, Sylvia, we got to move on. We have 15 minutes left. Barbara Cheney,
Make one
please.
quick comment on the interstate highway system.
Speak up, please.
I'm sorry. I wanted to make one quick statement about the interstate highway system. I don't believe that the majority of the people in the United States then, and I was even alive then, were against the interstate highway system. I believe at this point in time, all of the polls are showing that the majority of the people are against this. We don't even know what bill we're talking about, first of all. I mean, there are all these ambiguous things being thrown around. We're having a discussion here about something that we don't even know what we're talking about, really. That's going to be what's going to be out there. But my main concern is that earlier in the discussion, we were talking about who is going to basically bear the burden of this situation. And we were talking about basically it's going to be the, quote, wealthy younger people that are going to, you know, kind of carry this on their backs. The older, sick people, which will eventually be me, will be carried on the back of, say, my 32-year-old hardworking engineer daughter, who has been a hard-driving person her whole life, has worked hard and is hoping to achieve some form of the American dream, and she will hopefully, and she is now in a limited way, fairly successful, certainly not rich, but she has her own home that she's paying on and trying to achieve her version of the American dream. And what you're so casually throwing off, Carter, as I remember you had said, well, yeah, mumble, yeah, it'll be on the backs of the wealthier, younger people. I'm loath to do that to my children, and I believe that most of the people in this place here feel the same way. It's not just the health care. It's all the other things, the bailout of Wall Street, the bailout of the cars, the bailout of all the other things that we're doing, the mortgage, people that made bad decisions and bought houses they couldn't afford. This is all being absorbed by my child, our children, and I have a real problem with that.
Okay.
First of all, just as a matter of empirical evidence in life, younger, healthier people always in insurance pools are subsidizing sicker, elderly, childbearing age women. That's what insurance is. That's what pools are. If you get sick, I would venture to say, I don't know the crowd, but I'll say this statewide in New Mexico. I would say there's not 5% of the population of the state of New Mexico that could bear the cost in their own family without going bankrupt of a major HIV/AIDS or cancer or some other kind of catastrophic illness like that. That's why we have insurance, and the sick people get, you know, we just as a society, my taxes help to pay for a terrific woman to get terrific cancer treatment, largely publicly funded, I think. I hope I'm not overspeaking. Senator Tim Jennings' wife, wonderful woman, fought for health care for her whole life. Her costs were in the millions of dollars. We do this every day in this society, whether it's public or private. This isn't a public or private thing. That's what insurance pooling is. That's what health insurance is. It's not like life insurance where we rate people according to, well, I think they're going to live this long. We just don't. No insurance company does a pure rating system, because then the sick people would never have any treatment at all. So that's the first thing. And to your broader point, I agree with you. I think we are putting a ton of debt on our children. I will say this in fairness. A lot of the people who are complaining about it now were really quiet the last 8 years. And I will complain about it from back then and for right now. This isn't a partisan thing, and people should have a little self-awareness about, did I just start to hate it when Obama got into office? Well, wait, so I agree with you. These debt issues are big. I will also say that most economists, including a lot of conservatives, and Michael can jump in here because I know he's done a lot on the stimulus too. I think he's certainly aware of it. A lot of conservative economists were saying that we needed some kind of stimulus to avoid a really severe recession or depression. Now, the conservative angle was tax cuts. And more liberal economists were saying infrastructure spending, that kind of thing. We ended up with a mix of both. Most people got tax cuts in this stimulus package. It's a mix of both spending and tax cuts, which of course just exacerbates the debt problem. But my recollection at the time of the stimulus debate was there were a lot of conservative economists saying, yes, we do need to spend money now, because if we don't, we go into a death spiral that's going to take us decades to get out of, and we'll still have just as much debt because we still have all this infrastructure spending.
Michael,
If your daughter finds it difficult to pay the Obama health tax, I suggest you cash in her shares of GM. Yeah, I mean, how many shares of this company do I own by now? No one has asked me the question that I wanted to be asked yet, so I'm going to answer it because Carter provided me an entree, and it's that it's about how health insurance markets work and what happens when you prohibit health insurance companies from. Before I even go there, let me ask this. How many here would say that they don't like the idea of insurance companies setting premiums according to the risk of the people who are purchasing? So they don't like health insurance companies charging sick people more and would like to prohibit that. How many would say they'd like to prohibit that? Okay, this is a Rio Grande Foundation audience. This is not not representative of the audiences to which I usually speak, because usually that gets almost unanimous support. And that's why the president is talking about banning insurance company practices where they deny or exclude coverage, or deny people coverage or exclude coverage for pre-existing conditions. There's a problem though, that what he's effectively trying to do is he's trying to control the prices that insurance companies charge to people. Carter called it guaranteed issue. It's not really that. You can require an insurance company to issue health insurance to anybody who comes. But it's not until the government starts controlling the prices of that health insurance that regulation really has bite. I mean, the insurance company could say, oh, you cost, we're going to charge you a premium of $50,000 a year, but you know we're issuing you a policy just like the government asks. It's not until the government says that they have to charge you a $10,000 premium for the policy that's going to cost them $50,000 that regulation starts to have some bite. And the president talks about this as though it's got widespread support, it's the greatest thing since sliced bread. Who could be against it? Well, actually, I can think of a number of reasons to be against it. What do you think insurance companies are going to do when the government says you have to sell a $50,000 policy for $10,000?
$20,000.
Well, sure, but let's say that the average premium is already 10. Okay, what's going to happen in a market where people can choose any health insurance policy they want? Whenever they go there, they have to be charged the same price as everyone else, even if they're going to a $50,000 patient and the average premium is $10,000 per year. Meanwhile, a $5,000 patient is still going to be charged $10,000. Well, what's going to happen is this: the insurance company, well, the $5,000 patients are going to say, forget this. I'm not going to go to that comprehensive plan where the premium is $10,000. I'm going to go to this other plan over here where the premium is, say, $7,000. So I'm only getting gouged $2,000 instead of $5,000. So when all those healthy people leave that $10,000 plan, and you have nothing but $50,000 patients in that plan, what's going to happen to the premiums there? They're going to go up until they disappear, until those comprehensive plans disappear. That's what Obama advisor David Cutler found happened in the price-controlled health insurance exchange at Harvard University. To forestall that from happening, what are the insurance companies going to do? They're not going to just sit on their hands. They're going to say, gosh, these $50,000 patients are really killing us. How do we avoid them? I know, let's drop benefits that they really like. Benefits that would attract them will drop so that they'll go to our competitors rather than come to our plan. So they'll drop those benefits. There's evidence of that happening in the price-controlled federal employees health benefits program, which is the federal government's exchange for federal workers. this is going to be exacerbated by the fact that all those $5,000 patients are going to sit in the less expensive plans until they realize, wait a second, I need surgery on my shoulder next year, so I'll opt for that comprehensive plan, have it cover all my, because I'm going to be a $50,000 patient, but just for a year. So I'll opt into that plan and then opt out. That's more adverse selection. And what happens over time is the comprehensive plans disappear. All the plans get less and less attractive to sick people, the very people you're trying to subsidize. And it's all because the government is trying to force people to subsidize the sick. When you try to do that, people catch on and they try to avoid it, and they avoid it in ways that actually end up harming the people you're trying to help. The great benefit of markets, and like I said at the beginning, perfection is not an option here, but the great benefit of markets is that they do find ways to make, to bind insurers to the commitments they have made to sick people, so that when people buy health insurance when they're healthy, and then become one of those $50,000 patients, they don't get dropped. If they do, there is recourse, and I think there's, I believe, a strong role for government in terms of enforcing health insurance contracts if the insurers are violating them. But trying to achieve this through a price control basically causes the entire health insurance market to unravel, and is yet another reason why we're going to have less choice if that bill becomes law, and why a lot of opponents of this whole approach to healthcare reform are opponents to it, because they think that it is going to destroy private health insurance, if not in name, then at least in fact, and turn it into a government program that's run through the private sector.
Okay, we're going to disperse with response to the last two questions, then you can roll it all up into one big conclusion, because we are rapidly approaching 8 o'clock witching hour. Ted Cloak, please ask a very quick, concise question.
I'll make it as concise and quick as I can. Great. I'm a veteran, I'm a senior, obviously. Very, very happy with the medical care, health care I have. But I have one big concern, and that is, I think I might very well need long-term care or home care. Now, the Conyers bill, House Bill 676, covers that. How would either of you gentlemen handle the problem of long-term and home health care?
Okay, make a note on that. And Mackenzie Bishop, we will have our 10th and final question.
Forgive me for writing this, I just want to make sure I got it all. The market-based approach has been villainized, but with regulations that create geographic monopolies and antitrust exemptions, have we really had a pure market-based approach? And that being said, wouldn't a pure market-based approach with none of these regulations give us true choice? So denial of service, I could go to a private provider that doesn't deny my service. And to go back to an analogy that Mr. Ross used, you know, I don't like Diet Coke because it's unhealthy and too sweet, so I drink Diet Coke. You know, so that's a good market, but we don't have a pure market-based approach right now.
Thanks, Mackenzie. I'll let you, Carter, start.
Yeah, on the second part of that, look, that's why people talk about government being involved in healthcare, because a pure market approach doesn't work. First of all, we agree that we don't have a real free market system in this country for healthcare, but we're closer to a free market system than any developed country, certainly. And I do think that there are certain intrinsic qualities of the healthcare market that just make it impossible. Just listen to Michael's last answer. He's talking about how insurance companies ought to be able to issue these $50,000 a year plans to accurately reflect the true cost of those people. And he's right. I mean, that is what a lot of people cost, if not more. I don't know about you. I don't have $50,000 lying around for every year. I mean, so a pure market approach really doesn't solve getting to health care. It depends on what your goal is. If your goal is to have an industry where it's possible for some people to make large profits, then maybe a pure market approach is best. If your goal is to provide health care, not necessarily health insurance, health care to every American, quality, affordable, as inexpensively as possible, you have to look at the underlying drivers of cost, which we were talking about before. Some of the high-tech stuff, some of the overuse, defensive medicine, including overuse in Medicare, that's absolutely right. Some of the fraud. We have to tackle some of those cost issues. But I think putting it straight out to the market, the problem is that these middlemen, their incentives are completely misaligned from offering good health care. You gave the example of somebody denies my claim, I'll just go to another provider. Okay, Blue Cross Blue Shield denies my cancer claim, right? Because they found me a picture in college smoking a cigarette. You think Press is gonna take me? You think Loveless is gonna take me? Good luck getting coverage from anybody. You're dead unless you get basically government indigent care, which the taxpayers and other premium payers are already paying for. But now you only get it when you're super sick and it's expensive to treat you, and you tend to get it in the most expensive places possible, like emergency rooms. So this, one of the fundamental issues in this, and you raised it, is the healthcare market like soda? Can you just jump around from choice to choice? What are the consequences of a bad can of Coca-Cola? You know, we regulate Coca-Cola. It doesn't seem like it. We think of this as a free market. They've got all kinds of FDA regulations on them, and that guarantees that we have safety. But once we do that base level, we don't care. Market it, sell it. As long as it's not killing people, you're okay. The problem is in healthcare, everything can kill people. So that's why, that's one of the many reasons it doesn't quite fit into a traditional market approach.
Carter, anything on the, before I kick it to Mike, long-term care issue or wrapping up?
You know, I don't know enough about long-term care to give you a good answer on, but I think that's something that, I know part of that is included in Medicare. My great aunt right now is very ill, and she's been sick for a while, and she's been getting really good treatment, including in a nursing home for some of it. But Michael probably knows a lot more about the current long-term care options than I do.
Well, I think HR 676 promises all things to all men and women. I don't think they can possibly keep those promises. As I said before, tax rates are going to double by mid-century just to keep the existing promises. So I believe that they want to cover long-term care, but what is it going to look like? I think that you know, if you're familiar with the VA and how you have resources being allocated on a bureaucratic basis there, sometimes they run out of money. There's shortages in some areas and surpluses in others because they don't have price mechanisms to help them do this. You can expect to see some of that in long-term care under 676. And I would note that there are a lot of really promising, like in the private health insurance market, in the long-term care insurance market, there are a lot of really promising options. Long-term care insurance options that provide secure coverage against the cost of long-term disabilities, and that provide it in settings that you know aren't necessarily nursing homes, so that it's better tailored to the needs of the individual. Right now, we've had experience with the government program basically crowding out private long-term care insurance as best it can, and long-term care delivery. That's the Medicaid program. And it's a nursing home care-based model, and there are any number of problems with that approach that I think would be probably replicated under 676.
Well, that's why 676 has home health care as another option.
Well, but the problem is not the particular delivery system that they chose, but the rigidity that government brings to all of these decisions. The rigidity in both deciding what it's going to cover, how it's going to cover, and then it doesn't adapt over time as people come up with better options and better ways to meet those needs. I mean, the fact that when did Medicaid start covering long-term care? Was it in the 70s, and it adopted a nursing home care model? And how long is it taking it just to make this simple changes toward home health, which are much more patient-friendly? I don't want to have to wait for the political process to make these very important changes to improve the quality of care that people receive. So I think that's my answer to that. And as for Coke and Diet Coke, I'll refer my right honorable friend to the answer I gave some moments ago.
Any final thoughts from either of you guys? Or you can certainly visit with them afterwards. I don't know what time Michael has trip scheduled back to Santa Fe. Anyone change their opinion? Do we have any converts one way or the other? I'll just assume the status quo. Okay, Carter, go ahead.
Well, I just like to emphasize, I didn't really spend much time talking about alternatives to the reforms that are being proposed on Capitol Hill right now, maybe not Capitol Hill. But there are some. One of them is letting people purchase insurance from across state lines. But I don't even think that's the biggest change that we can make. The biggest change we can make is to change who controls the money. If you look at healthcare spending in the United States, about half of it is already controlled by government. People say we have this free market already, it's failed, and I'm like, what country are you talking about? Worse, on top of that, another 25% of what we spend on healthcare in this country is controlled by employers because of a tax policy, which is sort of a historical accident. It gives employers control over the earnings of their workers and lets the employers choose their health plan. So near 75% of what we spend on healthcare is controlled by someone other than the person that the system is supposed to serve. So I submit to you that any economic system, capitalist, socialist, whatever, any economic system is going to serve the people who control the money. So if you want to reform healthcare, if you want to make it more responsive to individual patients, if you want it to improve costs at the same time, reduce costs at the same time it improves quality, the way to do that is to let the right people control the money. Change the tax code so that employers don't control that money anymore. The people who earn it control that money. Change the Medicare program. So instead of this enormous apparatus that lends so much rigidity to our healthcare sector and subjects most of our healthcare to price controls, give seniors, if you want to subsidize seniors, great. Give them the money and let them purchase the health plan that they want. Let it include long-term care insurance and let competition and the ability of the consumer to avoid bad health insurance plans and bad providers, to discipline the marketplace. And I think that we will end up in a much better place if we live under the legislation that's currently before Congress.
I'll take that as Michael's final statement. Carter, your final thoughts?
I'm actually really glad he brought that up because that's an important topic that we didn't cover. This idea that if only individuals controlled the money, we would have much less use of the healthcare system. I don't think that's true. One of the most common things that you hear is that if you make certain things free or lower cost for people, they're going to overuse them. That's absolutely true if you reduce the cost of an iTunes purchase from 99 cents to 9 cents, for example. I'd be on my computer right now downloading a bunch of songs. At $1, I don't really use it. But you can make chemo treatment free tomorrow. I'm not going to go get cancer. It's different from any other type of market because there are so many losses and costs associated with getting ill other than just the pure financial cost. It's terrible to be sick. You can die. You're restricted in terms of the activities you can use. So I think this idea that if only the individual controlled the cost, we somehow would have a lower cost system is completely false. Now maybe if you want to talk about incenting providers like doctors and hospitals to be smarter about how they use MRIs and CAT scans, I'd be willing to buy into that because I think there is an issue about overuse of medicine, both in the public and the private sector, sometimes for different reasons. I think that absolutely is a cost driver that we need to address. But you're not going to address it with the traditional market approach of having the consumer control the money. And with that, I think we covered a lot of stuff. I really want to thank you as an audience because I know this isn't, look, I'm from a government employees union. I'm probably your least favorite person in the state. And you have been uniformly respectful, and I think if you look at the town halls in New Mexico, I think on balance we've been a lot more respectful than people in other states. And that's the kind of democracy and that's the kind of debate we should be having. So I want to thank all of you for...
Let's give our panelists a hand. They'll be duking it out again on the air on Bob Clark's show at 9 to 10 a.m.
Yeah, you said you were doing that with me.
Oh, no, we've got you going up against them. We've already done our on the air. Please fill out your cards, find out about events like this again in the future. Help yourself to food. We have cream puffs out there, for God's sakes, while other people are paying for your insurance. Load up on cream puffs. And babe, you got a question right here.
Michael asked Bill Gates for the seed money to start a separate company.
Bill Gates is really in the healthcare business.
You know Bill Gates, will you do it?
I do not know Bill Gates.
All right,
I don't think he gives me money under any circumstances.
Someone by the front door, I can take it. Hey. I agree.